So the idea of today's webinar was to explain a bit our experience with liver kidney transplantation in kids and do a quick overview of the main indications of liver kidney transplant. So basically we can actually classify, there's been lots of different classifications, but one of them could be for the indications of combined liver kidney transplant. The first, primary diseases that independently affect both liver and kidneys. It can be because both organs are equally involved, like for example, in autosomal recessive polycystic kidney disease and congenital hepatic fibrosis, or liver dominant diseases, but then that actually after affect the kidney, like could be, for example, kids with Alagille syndrome, or kidney dominant diseases that with usually less severe liver involvement, like the dominant polycystic disease. And on the other hand, we could have like primary diseases that actually involve the liver that eventually lead to kidney failure. For example, primary oxaluria or methylmalonic acidemia. I'll just go through the three most frequent that we actually transplant, just a few slides of each. So the autosomal recessive polycystic kidney disease is a rare disease with an incidence of 1 in 20,000 because of mutation in PKDHD1. And basically what we have a defective gene that encodes for fibrocystin and leads to defect of the tubular formation in the renal tubules and hepatic bile ducts, and usually early development of cysts. There are severe variants that actually go with pulmonary hyperplasia and with a high neonatal mortality. Around half of the children with this disease will have an end-stage renal disease during the first decade of life, quite early. Hepatic fibrosis can also be seen in early life. And usually what we're going to see is recurrent cholangitis or signs of portal hypertension. But chronic liver failure, basically, the dysfunction of the liver, does have a more variable age of onset, as we'll see. In this registry from now a few years ago, that went through 202 patients, all in pediatric age. The first transplantation of the majority of them, as you see, was the kidney in an 80% of cases with an age of 9 years, more or less, with a survival at 5 years after a transplant of more than 97%, and combined was in 50% of the patients, but these were younger, so probably with a more severe disease, but also the survival was quite good 5 years after the transplant. For the liver disease in these patients, as I was saying before, all of the patients had normal synthetic liver function, but usually it's the portal hypertension that is the problem in these patients. Primary hyperoxaluria, on the other hand, is also a rare disease. It's because of the mutation in AXVT gene that encodes for the enzyme alanine glycosylate aminotransferase. Basically, what we have is an accumulation of oxalate deposits that form crystals with the calcium in the urine. You get the stones, nephrocalcinosis, and basically renal failure in these kids that need intensive MRD filtration. And actually, this should be continued after transplant to remove the excess of oxalate, at least for the few days or hours. And what we see in these patients is in the few registries or publications that we have on transplant of more patients is basically a 10-year overall patient survival, more than 80%. And when we talk about the liver or the kidney, liver would be around 85% and kidney 75%. And last but not least, methylmalonic acidemia, as you know, is an heterogeneous inborn error of metabolism. That basically what we're going to have in these patients is a chronic intoxication with methylmalonic acid, with affecting the mitochondria and different organs, and with a very important neurological impairment. But it also comes with renal failure as a long-term complication. We do know that these patients, even if we transplant the liver, it's not a curative option, but the idea is to stop the neurological impairment. In these patients, there's been reports on isolated liver transplant. Some very rare isolate renal transplant and combined liver kidney transplant. Last year, well, now a year and a half ago, the ERN, ERCANET, and MEDAP ERN joint an expert consensus statement on the recommendations on the kidney management of methylmalonic acidemia, and basically there's 4 clinical practice points that are important for today's talk, basically. So liver or combined liver kidney should be considered in all patients with severe disease, regardless of the genotype. And the indications for transplantation are the high rate of metabolic decompensations and a high burden of the disease and difficult metabolic control. And also, this should be considered in the young patients that have poor metabolic control, frequent hospitalizations, and obviously in case of long-term complications, as I said, with kidney dysfunction. It should be considered early and before this kidney dysfunction, as I said initially, not because it's curative, but basically to reduce the neurological risk, to minimize late multi-organ complications and the disease burden before it's too late. It's important in this patients remember that during the surgery, fasting obviously should be prevented by the balanced glucose infusion containing at least 10% glucose and electrolytes. Also add L-carnitine usually to these patients, and in case of renal dysfunction, chronic kidney disease, we should actually have a plan for dialysis just before the surgery, or at least plan how you're going to do it. And this overview of all European data from back in 2021, there were almost 107 patients that had been transplanted with various combinations of kidney or liver, kidney or liver on its own. And basically, obviously, there's quite a difference in survival depending on the severity of the disease. When or how do we transplant these patients? So obviously one of the options is to transplant both organs together, and the other one is to do one and then the other. How do we choose when we do the transplant and which type of transplant we do? It's going to be depending on why are we indicating the transplant in the first place. So what's the clinical indication? Is it primary hyperoxaluria? Then obviously we wouldn't do just first the kidney because we'll put a second kidney in and the thing is going to happen. So we do actually need to do at least first the liver, if not both. Current status of both organs, obviously, as I said, in, for example, the autosomal polycystic disease recessive, we may usually see that the kidney is more affected, but we do need to study properly what's the degree of the portal hypertension, because maybe even there's not liver dysfunction at the moment, it would be better to do both at the same time. Recipient general condition, obviously, and the experience of the center. Is the baby very small? How are we going to get both donors? So all of these things are going to have to come into consideration to decide if we do them both together or we do one after the other. And also there's always been talk about the role that the liver plays in immunoprotecting both grafts. We do know that at a certain point there's been various literature on the matter, that usually if the transplanted liver, functioning liver, is going to have an immunoprotection action over the kidney and have less acute rejections in both of the grafts. So what are the outcomes, both short and long, in liver kidney transplant? So this is a few years ago already, but it's a good wide registry of combined liver kidney transplants, 152 primary combined from 1987, which is a great registry, with 32 deaths, mainly because of infectious diseases and even cardiovascular diseases in the long term. In overall 1 year, patient survival was about 86%. 85%, and also for the grafts. And 5 and 10 years, obviously decreasing a bit, being better in the overall patient, obviously almost 80%, liver graft 73%, and kidney almost 67%. Obviously, these numbers are not down to they're not registered in period, so probably we would have now much better survival rates than back in 1987. But even so, it's a good number to have. On long-term outcomes, there's there has been a few papers on the matter. The first ran a those included 40 children. The majority had, as I said, because it's one of the most frequent recessive BKD, and basically these patients had statistically significant greater decline of the glomerular filtration rate if they only did kidney. Also, crude rejection was less prevalent, as I said, when they did the combined liver kidney, and there were actually better outcomes in these patients than in primary oxaluria type 1. And then our group, almost 10 years ago, also published our experience at that point. It was 14 children with, and also what we saw as the long-term outcome also was related to the primary disorder. Primary oxaluria patients obviously had slow improvement of the renal function when compared to the others. And we had a 5-year survival, renal graft almost 86%, and overall 92%. So what we did now, well, it was last year, but basically we went through the past 25 years of our experience with liver kidney transplant in kids, and we analyzed all demographic data, the underlying disease, obviously if patients had renal replacement therapy before the transplant, complications that these patients had, and then liver function, ultrasound imaging, protocol biopsies, and survival at the end of the follow-up. So we've had 25 transplants. So 21 patients transplant was simultaneous. One patient already had a heart transplant because of NEC8 mutation, and 4 transplants were sequential. The majority, well, it was more or less half and half, men and women, a bit more men, with a median age transplant of 9 years and a median weight of 25. But just to remark, 5 patients were less than 15 kilograms at the moment of transplant, and 2 were less than 10 kilograms at the moment of transplant. As the same in the rest of the series, the most transplanted patients with combined liver kidney were the recessive polycystic disease, followed by primary oxaluria, other ciliopathies, and methylmalonic acidemia. The 4 patients that had sequential were primary oxaluria, the other ciliopathy, and another patient that had complications because of systemic shunting. All of patients with polycystic had simultaneous liver kidney transplant. And as you can see, those that we did sequentially had a weight that was less, like, difference between 9.7 sequential, 25 simultaneous, and were much younger, like with a median age of 2 years compared to 9 with the simultaneous transplants. So baseline situation of these patients, the waiting time on list was a median of 3 months, with a maximum being almost 7. 5 patients had a kidney transplant before, had already had a first kidney transplant, and 1 of them had already 2. 64% of patients needed renal replacement therapy before the renal or combined transplantation. 14 with hemodialysis, 2 with peritoneal dialysis, and the two sequential transplants were primary oxaluria. And the median time on dialysis before the transplant was of 9 months. Just to talk about what we do during the transplant and when we do them combined. This paper came out last year from our colleague or surgeon colleagues, basically changing the incision of the patients, as you can see in this, don't know if you can see my marker, but anyway, you can see the photograph. Instead of doing 2 incisions, one inferior for the kidney and one superior in the abdomen for the liver, changing this incision just into one, and with much quicker recovery in our patients. And it actually permits both teams to work comfortably in both of the graphs. So for our 25 transplants, the length of the hospital stay was 7 days in the ICU median and almost a month in hospital. What we saw on complications was we had one intestinal obstruction, but then quite a bit more frequently, in up to 5 patients, we had like abdominal hemorrhaging, which didn't need to go back to surgery. But we do kind of usually see, especially when we are doing both of the graphs. And for medical complications, we did have 4 patients that had infections just after the transplant, the treatment with antibiotic, and got better. That was it. But also, remarkably, the 3 patients that had ascites that was quite difficult to treat. But eventually got better and didn't need any more interventions. For us, the liver, the most important complications that we had was biliary stenosis in up to 7 patients, with requiring biodegradable stent through interventional radiology, but with good graft function posteriorly. And 2 patients that actually had a thrombosis of the hepatic artery, but the patients with methylmalonic acidemia. It's also described it's more frequent in these patients. And for kidney complications, we did had 2 patients that had delay of the kidney function initially, delayed graft function. One with vascular complications. We had 3 of these patients, and of 4 patients that required renal replacement therapy, it was basically a median of 2 days after the transplant. As for follow-up in the patients with hepatic rejection, there was 5 patients, 20% of the patients that had been transplanted. In our center, we do protocol biopsies at 2 years after transplant, 5 years, and then every 5 years. So 74% of the biopsies that we did to our transplanted patients were for protocol. 2 of these patients had signs of rejection on the biopsy. And this is obviously, we're talking about patients that have a normal blood test and normal ultrasound, and the only thing that we find is these changes in the biopsy. So we increased their immunosuppression and did a biopsy a year later. One of them has not done the year already, but the other one has, and the biopsy now is absolutely normal. As for renal biopsies, our kidney team usually doesn't do protocol biopsies, but since we started doing ours in the liver, we usually also do at the same time a kidney biopsy. So almost half of the patients had biopsies because of indication, different indications, and a bit more than half had biopsies because liver was already doing protocol biopsies. And one of them we actually found acute cellular rejection, borderline. And in the patients that we did, because we already had thought about acute rejection, we found 4 patients had already cellular rejection, 4 patients with 3 patients, with chronic kidney disease, and 1 with oxalosis. The rate of rejection in the kidney grafts was 23%, and here you can see it differentiated between the patients that had sequential transplant or simultaneous transplant. And in in total numbers, we have more in the patients that had simultaneous transplant. 3 of the 8 patients that had renal rejection was in the first 6 months after transplant, and the other 5 after the first year. And the majority of the grafts that had that presented with a rejection did not share the donor with the liver graft. As for the 4 sequential liver transplants, 2 of them, half of them have perfect liver transplant function, no proteinuria, and a mean eGFR of 68.7, sorry. One of them immediately lost the kidney because of a vascular complication and had to get retransplanted, but now has a functional liver graft and eGFR 50 with no proteinuria, and 1 patient actually died because of a decompensation of underlying heart disease with both functioning grafts, both liver and kidney, after 5 years of follow-up. And for the 21 simultaneous transplants, the majority, 80.9%, have a functioning kidney liver transplant with a mean eGFR of 84.5 and normal liver function test and imaging. 5 patients do have proteinuria and 2 with nephrotic range, in nephrotic range. And then just 3 patients actually lost their kidneys, 2 immediately due to vascular complications and need to be retransplanted, and they were still kids. And after transferring them to adult care, 1 had functioning third graft and 1 was on hemodialysis, but with normal liver grafts. And 1 other kidney was lost because of chronic graft nephropathy, and actually also lost the liver because of cholangiopathy, and was retransplanted while he was still a child, and then transferred to adult care with both grafts functioning. And there was also another kid that died after simultaneous transplant because of a systemic adenovirus infection, and that was 2 years after the transplant. Patient survival is 96%. We just had those 2 patients that died. Kidney graft survival obviously declines after, during the years, with the 96% the first year, 91 at 3 years, and 87 at 5 years. And liver graft, we only lost the 1, so with the 96% of survival in 1, 3, and 5 years. So as conclusion, the liver kidney transplant is safe as an effective therapeutic option in different complex hepatorenal diseases in pediatric patients. The surgical procedure obviously has a higher rate of immediate surgical complications when we compare it, talking about just the kidney. But it does offer an excellent long-term results in term, obviously, both of graft and patient survival. And that's all from my side. So I'm open to any questions that you might have.